Our next speakers are Dr. Samar Rahal and Dr. Audrey Thurm. Dr. Rahal graduated medical school from the American University of Beirut, Lebanon in 2001, and she completed her pediatric residency at the Cleveland Clinic Foundation in 2005, followed by a fellowship in pediatric endocrinology at Riley's Children's Hospital in Indianapolis. Dr. Rahal then went on into clinical practice as a pediatric endocrinologist at Peyton Manning Children's Hospital in Indianapolis for 10 years. In 2018, she moved back to her hometown of Beirut, where she was an assistant professor of pediatrics at the American University of Beirut. She then joined NICHD in 2021 as a staff clinician in the office of the clinical director. Dr. Rahal is a pediatric endocrinologist affiliated with National Institutes of Health in Bethesda, Maryland. Dr. Audrey Thurm, PhD, received training at DePaul University and Boston Children's Hospital, Harvard Medical School, and conducted a postdoctoral fellowship at Johns Hopkins School of Medicine. She's been at NIMH since 2002, serving in the extramural program until 2006 as chief of both the Autism and Social Behavior program and the Compulsive Repetitive Behaviors program. In 2006, she moved to the intramural program to help launch the Autism Research Group. She has expertise in longitudinal studies and an interest in markers of the early diagnosis of autism, as well as genetic conditions associated with neurodevelopmental disorders. Ladies and gentlemen, Dr. Rahal and Dr. Thurm.
Hello. We know we're the last talk before lunch, but we still have a lot to say. How do we move?
Let's figure out how to move these slides. The green.
Yeah. There we go. Okay.
Thank you.
So, as affiliated with NIH, we need to say that we have no disclosures. And so we're going to kind of try to step back a little bit and talk about outcomes. We know we always say kids, 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 and we do love kids, but we also know that kids grow up, and we see some lovely young adults here and adults. And we also just want to kind of take stock of the very long history now of research that has happened at NIH, thanks to Dr. Porter and several others here. And so just to kind of show where we are with some of the data that you all have helped so much, and you all know what you've done to help collect this data, and sort of what it means on a larger scale in terms of outcomes. And I focus on the developmental behavioral piece, so that's what we're going to focus on in relation to cholesterol. You'll see in a little bit, and you can try to see how these things come together. And then I also want to just talk about all this in terms of prepping for more clinical trials to come, because that's the whole point of getting this natural history data, is that it can be used to understand the condition, but also the measures that we're using, and you all know, because they're not perfect, but that we are using them, experimenting with them, trying to figure out better measures to help us, because we think that what you all say is important is the development behavior as outcomes, and so just where we are with that a little bit. So the reason why we need to, what we call studying the longitudinal trajectory, is really what happens to kids over time. When we see kids at one point in time, it's very helpful, but getting data points over time is what helps us to really understand within an individual how kids change, which is a lot better than just getting different time points from different kids of different ages, because as we know, this condition is so different in different kids. And we also think there may be differences over time in who's getting diagnosed based on better genetics, better detection. And so we really need to know within individuals how things change over time. So we need to just examine individuals. And we also really need to emphasize that that adults are incredibly important to evaluate, not just for lifespan, but for what's happening, what are outcomes, because that's going to help us figure out, again, what we're looking for as success in trials. And so we call it phenotyping. You've heard that term already. And the idea is that developmental phenotyping is the idea that the trajectory, what happens over time, is the most important thing. So because there's so much variation in cholesterol in development, we need to really make sure we're looking over time, and then figuring out what are the most important sort of predictors is important to look at. So Dr. Porter already showed this, but I think this graph just gives us an idea of how helpful growth is, and these growth curves can be obtained from getting individuals at different points, but you really need to see the growth in individuals. So this is just, I wanted to show this in the beginning to show that we all understand height and weight as, and Dr. Porter so greatly showed, where you are, maybe where you are within SLO, but in the real world, like in schools, people are gonna be sort of rating you based on where you are, in the general population. And so we want to be able to have both of those in our heads when we're thinking about outcomes for these conditions. And it's easy to do with height and weight. You stand on the scale, you measure, but it's a little bit harder with development because it's such a moving target and there's so many factors that we have a hard time measuring. Absolutely. So I just put in here like a little bit of the history because it's been mentioned a few times, but just that these differences in how the condition was identified and hopefully getting diagnosed earlier and earlier, we think can have an effect. That's the whole point, is that the earlier the diagnosis, the more we can be sort of tailoring the treatment, not just in learning in school, but also in what behaviors to expect, and certainly in trying to improve cholesterol levels over time. So I think I'm making the case, but I'm just going to keep on making the case, especially because we're just trying to emphasize and thank the families who continue to come back, and just because involvement in research is just so critical and not easy. So this is actually not about SLO at all, but a model of clinical trial readiness. And I just wanted to kind of make sure that I talked about this, is that what the trials need, you cannot do a trial if you don't know what you're looking for as an endpoint, is they need to have natural history data to know what time window in the entire lifespan you'd want to look at and you'd want to focus on. I think we all know earlier is better, but we need to understand what the endpoints would be if you did try to do trials that were across the lifespan, and how those would differ based on what age you would be looking at. So this is just a schema for all conditions that we're thinking about as we're trying to figure out what we need to do. But the natural history data is the starting point of this. It's the most important thing to get that. And this is the roadmap that the FDA puts together, which is actually really complicated, and they're still figuring out themselves how this applies to very rare genetic conditions where you don't have thousands and thousands and thousands of kids, where you can easily get surveys and get data in multiple places around the country or world. But again, it's the same idea. And I really want to emphasize the first thing they talk about is the patient caregiver perspective. And I think we're going to be focusing on that a lot more now. But again, the natural history and whether subpopulations are critical to having different outcomes. And then the idea of what are the concepts of interest? What is most important to the patients and families? And then how you define that within the context of a trial. And so this is where this idea of the clinical outcome assessment, what the measure is that you're going to be using, comes in. And they come in different forms, and you all know this from being in the research. Some of it, and this is why we have to test the kids, even though it's not easy, is that these are what's called performance-based measures, and the FDA loves these because they are saying this is directly from the kid. This is what the kid is doing. They think this is ground truth. the gold. You all know that it depends on how your kid was feeling that day, what they ate, many things. And so that's why there are other types of measures that include clinician ratings and also observer ratings, which is the parent questionnaires that we so much are grateful that are being done. And then this all gets put together into for each trial, into a concept for what's used. So now just kind of getting into to what we would do for developmental measures for different conditions is we have to figure out what the range is of cognition, intellectual disability, and then all the other possible behavioral dimensions that come with it that we all know about that have been mentioned, and sort of where each condition fits in. And some are really, really broad, where you have to cover the entire range, and some are more narrow based on genetics and what we know about mechanisms for those conditions. So SLO is one of those, and this is a schema for intellectual disability here, which is kind of a framework for how we think about it. This is my opinion, but this is also what the data is showing, is that it is definitely a condition that covers that entire span. I wanted to make sure that that's sort of this framework, that there are some that don't, but SLO is one that does. So I'm going to turn it over for more about what we've done.
Thank you. So this is a perfect segue. So with the understanding of why these natural history visits and natural history studies are important, I wanted to give a little overview of our NIH natural history study that's actually been going on for over 25 years. So we started recruitment in 1998, and all individuals with SLOS are eligible to participate, regardless of age or where they live in the world, et cetera, or genetic diagnosis or how the diagnosis was made. And the interesting thing about this study is, as I look back at the records from all those years ago and now, is that it's actually very dynamic. It's evolved over time. What I mean to say by that is that a lot of the investigations that were done back in the early 2000s, we don't do anymore. And for those of you who have been coming all these years, or a few times over those years, you know what I'm talking about. At some point, everyone got a brain MRI because we were looking at that, and this data has been published way before I started on this study. And we found that it wasn't necessarily something you have to do routinely, so we dropped that. And other things we've added, so for those of you who've come the last few years, you've noticed that we're probably starting to do more cardiac workup, for example, because we want to look at heart issues as these kids get older and become young adults. Or recently we've added DEXA scans, trying to look at bone strength and bone maturity, etc. So this is a dynamic study that changes as we get more understanding over time. So currently, these are our ongoing evaluations that we do for everybody. Neurodevelopmental evaluation with Dr. Thurm's team, speech and swallow, always a major issue because of feeding and speech, etc. OTPT when needed, cardiac workup, like I said, ophthalmology examination for everyone that frequently takes place under sedation, so we can get a better view and more data and more time with the patient that way. Audiology testing similarly, and obviously dietitian and GI consults, very important, as these are always issues that are pertinent and important, especially with the younger individuals, younger kids. So for the next few slides, I'm going to be showing you what we've learned since 1998. Obviously not everything, and this is a little bit still preliminary data. We're still cleaning up, and we're still we're still confirming and all that, but it will give you a general view of what we've learned and kind of put into perspective what Dr. Thurm was talking about, why we're doing what we're doing and what we hope to achieve, and why, when you guys, a lot of you here in the room and some at home, when you sit with me for 2 or 3 hours, it gets tedious. I know we ask a lot of questions. You're always so patient answering. these are your answers. This is the data all put together, basically. And even sitting in this room today, just this morning, I was writing notes on things that I know we have the data for, but we haven't looked at, and I'd like to look back on that. One of them is, what age are we getting diagnosed? I think it's changed over time, but we haven't actually looked at that data, but I know we have it. So that's something I can go back and look at. Other is sleep. Dr. Porter mentioned something about sleep, and I know we haven't looked at it, that closely. I can tell you anecdotally, I know sleep is a major issue as the kids are really young, but it becomes less of an issue as they get older. But this is data we have sitting there. We just have to pull it together. So in the next few slides, like I said, I'm going to present what we've put together so far, and hopefully over the next couple of days get ideas from you of what we can also be looking at. So this answers the question from earlier this morning about what age is the first visit happening at the NIH. The black line in the middle of the graph is the average. It's the mean. So it's somewhere between 5 and 10. But you can see a big cluster underneath that, meaning that they're coming, very young as babies. But then we have first visits happening as old as 40. I think that's rare, as you can see. Most of them are happening in the childhood years. I did want to introduce, he's not here, but Garrett Bowman is the IRTA who's been working with me for the past year on this study. And the reason I wanted to introduce him is he's listening from his office at the NIH today. But he did put all this data together. So I did want to give him credit. He's been working over the last few months as just the next few slides that I'm going to show you, a lot of it is him going through chart by chart by chart and putting this data together. So I did want to give him credit for that. So to start with, what is the range? So we've heard over and over this morning, and I'm sure we will over the next day and a half, that there's a wide variability, a wide range in severity of presentations. And so this is from our population, again, of the 130 individuals, and this is their severity score. So it ranges between 0 and 60. The next slide, I'm going to go over it a little bit because I find that not a lot of families are familiar with it, but we do have a wide range of severity. And what this is a score that looks at different physical malformations that are present, usually typically at birth. So this is a score that looks at things like, I'm just not going to go over the whole thing, but it's available online if you wanted to look it up. But things like if there's 2-3-toe syndactyly, which I would say over 90%, like Dr. Porter presented earlier this morning, but also this polydactyly, meaning an extra digit, so that gives you a higher score. Things like the eye, if there's cataract, that's going to give you 2. And etc. It just scores every organ system. So we put those together, divide by the total, which is 20, the highest score you can have, and then it's kind of like a percentage. So everything's on there. But if you look at it closely, you'll notice that things like development are not on there. So cognitive development, when they're 5 or 10 or 15. Communication ability, whether expressive or comprehensive, it's not on there. Whether they're feeding by mouth or by G-tube, whether they're ambulatory or not. So it's not the most perfect of scores for that reason. But it is one that is objectively available, can objectively be determined, and can be used when we're looking at other things, other data. So you'll see it in studies very commonly and very routinely used. And for the most part, it is useful. But I just always want to give you the caveat that it's not, that there are some issues there that could be, it's not a perfect score. So, but again, what I wanted to show earlier was that using that scoring system, because it's the best one we have, we do see a wide range. 6 is the lowest usually, because 2-3-toe syndactyly gives you 1. 1 divided by 20 is 0.06. So 6 is the lowest, but then you can get into the more severe as you have more of these physical findings. So again, I just remind you, this is our data from the 130 participants that we put together. This is height. I'll go through it in a minute. Weight looks similar, so I didn't want to put 2 slides that look exactly the same, but we do have that data. So the A and B are female heights, C and D are male heights. So A is baseline. That's when we're seeing them at the first visit. And The line, the black line, again, is the mean or the average for that population. So the dotted line is the mean for the general population. So the black line and the orange is our patients, our participants, and the dotted line is the average for the population, general population. So as you can see, that for females and males, the average height at presentation is lower than the typical or the general population. What is interesting is for B and D, which is final height. So here Garrett looked at everyone who is over the age of 16, meaning they've achieved their final height. They're not going to grow anymore. So this gives us an idea about where we're going with this. And for final height females, it is actually much lower. Even as you look at the two standard deviations, it is actually much lower than the mean for the general population. So we have noticed, and those of you with older female kids maybe can tell me if this is accurate in your family, but the final height tends to be lower than the mean in general. And a mean for a female is about 5'3" to 5'4" in the general population. But males actually come much closer. So as you can see, that they actually touch on the mean for the general population. So males somehow do better catch up than females do. And the average height for a male in a typical general population is about 5'9" to 5'10". Do we know why? No, and great question. Actually, no. Is it hormonal? In general, men are taller than women because they have more time to grow. Puberty in women happens earlier. This is my endocrinologist speaking. Puberty in women and girls happens earlier, so they have less years to put on those inches than for boys. So in general, there's 5 inches. The typical, like I said, the typical female average height is about 5'4", 5'5", plus 5 for men. So whether that's playing a role, it could be, but I don't have a great reason. So another thing we looked at, again, this is data that, is hodgepodge basically, and we do have, I'm going to present most of what we have, but we do have some more cooking. Hopefully we'll keep looking at things. But this is surgeries, and this I think will come as no surprise. So for all the 130 individuals whose surgeries we have, what surgeries have they done, this comes as no surprise to you. Ear tubes, G-tube, and then for the physical malformations like cleft palate, heart surgery, etc. But the most common are very expected, like I said. So next few slides, I'm going to talk about also findings like in general findings. So this would be how many have had G-tube plates, about 50-50. But then about 25% were able to get their G-tube removed. And here I want to just point out that I have some patients, individuals, who keep their G-tube not for full oral feeds. So this doesn't take into account that. So some of them are leaving it in to take medications or when they're sick to be able to give fluids, etc. So not necessarily full G-tube feeds, but about a quarter managed to take it out completely and not need it for anything. And this is the age at which the G-tube was removed for those, not very many, 14 patients who did have it removed. So if it, usually before the age of 10, it's been removed. But this is a very low number to make major conclusions based on that. Ambulation means walking, and so the majority are walking. I should have put percentages there, but you can see from the pie chart, a good percentage actually are able to eventually be able to walk. It may not happen at the time that we would expect in the general population. And interestingly, this is data that came from a family that was just here last week, and we were talking about this. I'm like, we have this information, let's go look at it. And Garrett pulled it together within like a couple hours, so I can present it to you today. So the black line, again, is the average for our population, and you can see it's between 2 and 3 years old. It was actually exactly 30 months for the average for ambulation, but there's a wide variability, and some are walking closer to, up to 8 years. But the typical age where you expect a child to walk is between 12 and 18 months. So we're obviously a little bit beyond that, above that. This is behavior data. I left development data to Dr. Thurm, who'll take over after this. But we did gather that. It's not very detailed, and I think it's very subjective. Self-injurious could be as simple as biting your finger, or it could be, as severe as banging your head. So take that into account when you look at these numbers. But it is very commonly seen. Aggression, same. There's a wide variation in how people and what people use to describe aggression. But again, about 63% did report some degree at some point. And finally, tantrums. I mean, that's a tough one. All children have tantrums. Again, this is what you can tolerate and what you describe. We try to include tantrums that are so bad that going to the grocery store is a problem, going to a restaurant is a problem. We try to just, when it's a yes, it means that. But again, I think it's a difference in tolerance. And this doesn't mean that they don't go away. I don't know that we have that data good enough to be able to present. It just means that this is something that as a family you've dealt with at some point. And as far as the formal diagnosis of autism, we pulled this from Dr. Thurm's team's records, and that's a tough one. I know having that diagnosis opens up a lot of resources, and I think that when you kind of have to apply, very strict criteria, we didn't end up with that much. So about a quarter actually met the strict criteria of autism, but probably by report or anecdotally or having been seen in other places, more kids would report that they have this diagnosis, or more families would report that. I think this is my final slide. This is all the way into adulthood. These are all our adult population. I wish we had more. That is a typo in A. It's not 58, it's 18. I realized when I was looking at my slide last night, but I didn't know how to fix it without ruining the whole slide. But this is looking at what these adults with SLOS are able to do after childhood years. So again, over 18. So A is whether they're able to dress independently, and almost 70%. The 70% is accurate, the 58 is not, are able to. And this could be minimal support, like I'll put my shirt on, but someone needs to help me with the buttons, or the buttons are crooked, or so on. But a good percentage are able to at least do some of that. And the second B is for ability to make your own meals. This is not like a 5-course gourmet meal. It's more like grabbing a sandwich or some yogurt, just something that if the child needed to eat, they're able to do it. And about 50% are. And finally, basic hygiene. And I think that one's subjective too, I can take a shower, but it's not the best shower, so I need a little help with the hair or whatever. But again, it's about 60% who are able to take care of basic personal hygiene. And now I'm going to give it back to Dr. Thurm, who's going to focus on the developmental aspects and correlation with steroid levels.
Yes, I know, but she's staying. and feel free to jump in more, but we should applaud her. So with Dr. Tierney back in the room, well, first, we did a publication now almost 10 years ago where we looked at the data we had to date, and then now we are updating it. So in terms of measures that we're using, and again, focusing on what we'd want to put in trials, what Samara was just talking about of what we call adaptive functioning is actually functioning. The FDA feels, which we cannot do, that's self-report only, functions, which is what we can do, and what we think is important, and survival. And so functioning, we think, is really going to be the critical outcome. It's also critical for supports that families need in the here and now, that we really need to make sure that we're documenting well and help supporting families get. And so measures that can help us, certainly communication being critically important, the daily living skills that she was just talking about, including personal, which is taking care of yourself, hygiene, feeding, and doing things like that, including toileting. domestic helping around the house, are you able to live on your own? It gets at that. And then community, being able to go out and be in the community, all the way from being able to sit at a restaurant to being able to work and do your own finances. Socialization, which includes, from very young age, being able to have eye contact, play, and then coping skills, which does get at tantrums and the ability to sort of moderate yourself, regulate your emotions. And then motor, where we can get at the ambulation, and then even other motor skills. And of course, we also look at maladaptive behaviors in different ways. So that's what we get from observers, caregivers, and that's why it's so critical that gets paired with our IQ testing, with our ability to look at both verbal and nonverbal or kind of puzzle-based skills. And we put those together when we make a diagnosis of intellectual disability. We do not make a diagnosis just on one of those. We put them together, and we use those critically to look over time. And we really try to look at how much these things correlate with each other, because that's when we know that our measures probably are not too bad if they're actually correlating with each other. And this is for SLO, but this is for the entire population and how schools and service providers are using these things, and what we think would be important outcomes in trials, in addition to specific behaviors that we've been talking about. So this was in 2016, and at that time our full sample was only 33, and this was actually combining the Kennedy-Krieger and NIH sample. Our NIH sample was really small then, but this is I think she's getting the autism rates from our bigger samples, but this is where we did get some differences. And of course, the difference here with the autism rates has to do with using the measures and then making a clinical judgment on autism. And this is where things like ambulation, because you can't even really use those measures if you're not ambulating and having a certain level of cognitive skill. So again, I've talked about this at this meeting before, and I'm happy to talk with others, or please ask Dr. Tierney, but it is not as simple as you hear about in the world of making a diagnosis of autism in this population. And then also things like understanding where the child is. And one thing I just wanted to make sure to point out about that is that you may be waiting longer for a diagnosis, or people may be not able to do it, or saying to deferring it for later. Again, because if you're young, if you're 2 and you're still not ambulating, you probably wouldn't be doing that at that point. But anyway, this is where we were with our rates of all these things in 2016. And then what we did find then, which I think brings together all the talks we've had so far, is both for the severity scale, but also for both IQ and adaptive functioning. We found really, I think, some of the most strikingly high correlations you can find for any biomarker of any condition relating to intellectual disability with in this population. So very strong correlations with how much cholesterol you have, and this is the ratio of the 7D and 8D that we heard so greatly talked about from Dr. Elias with both of these. And they correlate with each other, and they correlate with the amount of biomarkers found, both from blood and CSF. So this is very helpful to know that when we do trials and we see changes in those, whether it just be for cholesterol supplementation or anything else, it gives us a hint that that may affect IQ and adaptive functioning over time. We need to look at it over time to know that, and that's what we're doing right now. But this gives us a hint, because this was just from one time point. So then the new questions we're asking are, since there is a lot of variability, which you just saw in both cholesterol and functioning levels, how does this change over time? And do cholesterol biomarkers, continue to relate to neurodevelopmental functioning over time? And so this is where the data that has been collected is all plotted out here. So on the left are every Vineland, every interview that everyone's ever done. And it's just important to see, because it's amazing how much we've gotten. Yet still, we have so little data here in adulthood that we're going to be very, very limited for what we can say. And even though some families, some individuals, there's many, others, there's just one or a few. And so this does unfortunately limit us in what we're able to say when we correlate it with, this is all of the biomarker data we have over time. And again, it's amazing, but it's also limited. So this is just, we're going to be showing this, publishing this hopefully soon, but so this is just the data on one of the measures of adaptive functioning that we gave over time. And you can see here, when you use standard scores, and you all know this from life and school and other testing you've done, there is a significant amount with those floor effects, which is the lowest score, and that makes it really, really, really hard for us to then see change over time. But this is what it does look like over time with our newer measure, and you can see it looks like decrease, but again, it's mostly that the adults that we've seen have been those that have had those floor effects, so it's really hard to see what it really looks like over time from the conglomerate of data that we have right now. But we do have other metrics that are available with these adaptive functioning measures that are what we call gross scale values. So they can approximate what you saw with the height and weight of actual growth much better than those standard scores that we all see and are used in schools that are not helpful because they stay at the floor and they're no matter what. So we have these other metrics now that we're able to look at, and so it looks a little different when we look over time with these metrics. And so that's what now these look like over time with across the lifespan that we have in our data. So here is just a couple examples. This is expressive language, expressive communication, and this is personal. So this is really what the data are showing in terms of changes over time. And in general, we're seeing stability. So that's good to know, and it helps us, again, with planning for what we would expect in trials if we were going to be looking for this. I did just put here, compared to some other published data of some other genetic conditions, you are seeing the entire sort of range here, and that's important to know, just like I said, what to expect with other conditions. Then here, what we have, I know this is a lot of just gobbledygook numbers, but on here are cholesterol, the 7-dehydroxylase, the 8-dehydroxylase, and then the ratio. And what you see here is these are correlations with each other, and then with that severity score. And when you see all these stars, these correlations are all high. They're very, very high with each other, but they're also high with the severity scores. Again, just showing that the cholesterol matters even for, this severity score that is really focused on sort of the issues that are seen at birth. But then we also did it with the Vineland, and so these are all those subdomains that I was talking about, and all of them are quite significant in terms of large numbers. So basically, it's just showing that that all of the different cholesterol, and it really almost doesn't matter which one you use of these, are quite related to the severity, but also the adaptive functioning. And this is just from all the data. So this is not over time, but just all the data. And then finally, what we're going to start to do is really look at this over time. And these are just the plots for the different versions of the adaptive functioning scale that we have. And it looks better with the earlier version because there are just less floor effects from the older individuals. But you can see that correlation right there, that is strongly related to cholesterol ratio. And that is what we have. And now, definitely thank Dr. Hall, and we're happy to take questions.
We have our first question. Sure.
Some of us were involved in either Dr. Steiner's protocol, natural history at OHSU, or Dr. Irons had a program that wasn't natural history. But how is that? Because I know the protocols were different, and you can't use the actual data per individual, from what I understand. But like Aiden was there from 1 to 8, and now he's heading to NIH next week for the first time. How might there be some, I guess, looking at him long-term to provide? I don't know. I mean, the question is how to use the old data to help the new data, I guess.
I mean, that's a great question. We're always happy to collaborate. And actually, when we signed the consent form, we ask you for, the permission for us to share our data. And hopefully all consent forms are similar, where we can share data and we can look over time. Some of the measures might be different, especially from that long ago. I don't know, but a lot of the information would be very useful. So it's a small community. Not very many of us do this research. So if we don't work together, we're missing out on having like a lot more information. So yeah, good question.
Thank you for that question. Another question from the audience? I see one over here. Thank you, Theo.
Hello. Yeah, we were fortunate enough to make our first visit to the NIH last year, as you know. In terms of like the usefulness of gathering the data, is there like an optimal gap between visits you would recommend?
So yes, we were very happy to have you there last year. I think, depending on the age, I mean, and also depending on the severity and the ability to travel. I know you guys are from across the pond. When they're younger, a lot changes. I think this is very pertinent to what Dr. Thurm's team does, and their neurodevelopmental, basically, a lot changes very rapidly. This is true of any kid and also SLO kids. So when you're younger, doing it more frequently makes sense. There is a telehealth version where we can get a lot of the Vineland, I believe, data. Vineland is where we're looking at adaptive behavior score and all that can be done virtually, because we know that travel isn't always easy. With the older individuals and the young adults, I feel like going every year or even 2 because not much is changing over time. So I think it's a very specific to the patient and the ability of the family to travel and all that. But telehealth option is always there for gathering medical history, which a lot of what I presented came from that, but also for even developmental evaluations.
Yeah, well, I'll just add that we may change those intervals, time periods, based on prepping again for clinical trials, because this data is what we take to the FDA to say we want to do this trial in this age and this, and they together we may say, look at this at the rate of change. When kids are young, we think that there should be more intervals then, and that is because that's likely to be when we're going to eventually do trials, although sometimes we have to start with adults or older individuals for other reasons.
I have a question. You were saying you wanted older children in your trials. I have a 20-year-old grandson. How could I get him with you all?
Come talk to me. But yeah, I mean, we don't have a restriction on age for enrollment. So 20 is great, because I don't know if you realize with the data I showed, the young adults, when I started getting to the slides where, daily living skills and all that, we definitely don't have as many as we do for the younger kids. So more information there is always welcome. Yeah.
And I know the foundation wants to be supporting all the research, so
Okay, we're wanting to do this long term, right? So I'm wondering if you are all worried about funding at all, about our program, and if you are, do we have a plan B? If our funding gets cut, what can we do to keep the study going?
Well, I'll just
I'll let you.
I'll just say the foundation is so important. It is so important. And I will also just add that the reason why I bring up other conditions is because there are so many that have such similar issues, including dealing with the FDA and figuring out how to do trials. So joining together with other groups that, and it would be critical too. And I can talk to the foundation about that. But the foundation is, that's the entire point of the foundation. So avoiding talking about the government.
So we have two different online questions from two different individuals. I'll read them off to you. The first one, hi, I'm Angelita from Brazil. How often do we have to take the 7-dehydrocholesterol test?
That's a good question. I mean, normally I think we do them annually. It's a tough one because it's very difficult. I think Dr. Elias also touched on this a little bit. It's really difficult to make medication adjustments based on the 7-DHC and cholesterol levels. In general, I think most people are doing once a year if they're able to. I don't know if there's a better answer to that, Dr. Porter.
My bias has always been healthy because of the variability in the levels. If the children are sick at the time, my bias is sort of using, is the child growing well, are they healthy, et cetera, to sort of guide that, because rather than trying to react to a number that has a lot of factors wrapped up in it.
Yeah.
Different people do it differently.
Mm-hmm. I don't think there are specific guidelines on that one. Yeah.
Okay, and then the second online question is from Maria E. My son at NHI, when he was at 4 months, we live in the Dominican Republic. Can he be again at NHI? He is now 7 years.
Sure. Yeah, like I said, all ages and regardless of geographic location.
Hi, we participate in ABA therapy and have assessments done on an extremely regular basis. Would it be beneficial, or can you use those assessments in your research? And to say that we've been to the NIH with Dr. Porter and Biancani?
Yeah, this answer is tricky. I mean, first of all, it's great that you're getting frequent assessments. We use it when we make our clinical recommendations, when we evaluate the children, and it's so helpful. But for trials, the FDA is just going to always require that it be done, in a similar way from the same, professional. So it requires doing some of them over for the research piece. But having the information so that we can put it together and see how different or similar it is to what we find is really, really important. And there may be some trials that allow it, but it's been hard to convince them to take outside as the actual data.
Does it have to be in person?
No. And in general, I mean, we can't thank COVID for anything, but it did help us to get this stuff set up, even just literally being able to have Zoom, and then now we have standards for how we can do that. The Vineland interview can be done. You can be anywhere in the world. Having the video makes it a lot better, but absolutely. And there's more and more questionnaires that now we can do with surveys that we can work more with the foundation about how to help get that set up too. So there is a lot that can be done from home. It's just that piece where the kid has to do the puzzles, which we're trying to get that further removed from some of the studies too.
Thank you for those questions. Any other questions in the room or online? In that case, let's thank both Dr. Rahal and Dr. Thurm for their presentation.